Mind me introducing you, sir. This is Dr. Martin Grossman. He is the Hospice Medical Director, and he has many different roles in the company, but more than anything, is a tremendous human being that I've worked with for so many years, and I really thank him for being here today.
Now I feel bad I recorded that. I'm not supposed to record that. Thank you, Enrique. So it's a pleasure being here. Thank you very much for inviting me. And of course, I think as we go further and further on in our professions, in our careers, we understand the importance of teamwork, that the days of there being islands in medicine where somebody functions all by themselves are completely gone. The only way that we can function is based on our own training and expertise in order to care for patients, whether it be home care, whether it be case management, social work, physician, nursing. We have to work together. Because if we're not working together, we're certainly not helping our patients as much as we could if we were working together. So I just want to talk a little bit about some confusing terms. And this is how I usually start it, and I welcome any questions anybody has. Just remember, the only one that's being recorded, at least from a face point of view, is me. If you'd like, I could reverse it for you. But since no one gave you advance notice, we'll just, only my face is on this. The reason we're recording it is so people who are not here today because they couldn't make it or because maybe they have evening shifts, I'm going to send it to Heather and she can make it for everybody to watch so we can get help the education, not just for the day shift, but also for the people who are here sometimes at night and weekends. So the first thing we want to understand is if you ask most people, and no one in this room can consider themselves a layperson. We've stopped being lay people the day we set foot into nursing school, into medical school, into social work school. And then, of course, now that we're already doing this for a couple of years or 20 years, whatever it might be, we no longer can consider ourselves lay people. We are, shall we say, in the business, shall we say. But if you ask most lay people, I think it's even more so for people who are in the profession, if God forbid it was coming to your time to leave the world and to meet your Maker if you so believe, where would you want that to be? How would you want that to be? What would you want that to look like? 80%, 90% of people will say, if God forbid I knew I had something that was incurable, I would want to be home, I would want to be comfortable and surrounded by my family and loved ones. Correct? Yeah. And if you think 100, 150 years ago, this is precisely how people died. You think about the good old days, they would call the doctor who would come over with his horse and buggy. They'd have a chicken prepared for him, right, to give to him so he can take with him. That was his payment. He would come and visit the patient, see that the patient had some terrible illness, pneumonia, whatever it might be, before the days of antibiotics, and let the family know it doesn't look good. Gather together because, mom, dad, or whatever is coming to the end. And then people would pass at home. We see, given the explosion of medical technology over the past 50 or 60 years, and even in the past 20 or 30 years, what's happened is it's hard to die at home because there's so much we can do to prolong people's lives, to help people live longer, whether it be with medications, whether it be procedures and various other things. There's so much that we can do to prolong people's lives that most people are actually dying in hospitals. They're not dying at home. It's the exact opposite. 75% of people are dying in hospitals. So there's a little bit of a disconnect. There's a disconnect between the wishes of people, if they knew they were dying, to die at home, and the fact that most people are dying in a hospital. So it's either no one is telling them that they're dying, or that they're in denial that they're dying, or the family's in denial that they're dying, or they have some unrealistic expectations of what we healthcare professionals can do to help people live longer. And while we can do wonderful things to extend people's lives into their 70s and 80s and 90s, I don't remember the last patient I saw that was 120. And I'm sure if I ask anybody in this room, have you ever seen a patient that was 120? Most of us would say maybe 104, 105, 108. Beyond that, very, very unusual. Maybe 15, 20 years from now it'll be different, I don't know. But we see we can do wonderful things to extend people's lives. But the other thing we have to take into consideration, and of course this is based on the patient and their family's wishes, is the component called suffering. Because part of our mission as healthcare professionals is not just to extend life. Part of our mission as healthcare professionals is to reduce suffering. I would venture to say that if every physician, every nurse, every social worker look back on their essay, if you had to write a personal statement when you went into your schooling to get in, nobody in there wrote, well, I want to be able to park in front of the hospital with empty plates. Nobody wrote that. People wrote in there something about relieving human suffering, whether it be through nursing, whether it be through medicine, whether it be through social work. And unfortunately, sometimes we forget that. And the medical profession in and of itself, in many ways, forgot that. And I'm going to talk on behalf of the physician community, but I'm sure if nurses think about it a little bit, you know, what you thought nursing was going to be when you were in nursing school and actually what you're doing right now, it's not exactly the same for some of us. Social work, when you were going to social work, so you had certain vision about what it would be like to be a social work. And then somehow it's not the same. Well, I can say it doesn't have to be that way. And all of us, in our day-to-day, in doing what we're doing, all we need to do is open our eyes and remember what we wrote in our personal statements. In fact, I think a great exercise would be that if once a year, as part of continuing education, all of us had to look at our personal statements to remember why we went into this profession, and then to see whether or not we're living up to our expectations when we were lay people. And what we do is holy. We have to understand that. Whether one believes in God or doesn't believe in God, what we do is very, very holy and spiritual. We help people in ways that most people are not. When you have a customer going to a store to buy a camera, they help the customer to find the camera that they want. Okay, what's the big deal if they buy a camera that's not the one they were looking for? Maybe they got a little cheaper. Maybe they spent a little more money, got extra features. We're dealing with people's lives. If we make mistakes, if we make errors, sometimes it's not fixable. Sometimes it's permanent. And what we have to recognize is every day we go to work, what we do is holy, and we have to avoid bringing our home stuff, because all of us have different home stuff, right? And we have to avoid sharing that with the people we're caring for. Because as bad as your day is, and even if you could imagine it's the worst day, your boss yelled at you, they didn't approve your vacation time, they gave you an extra call when you didn't want to work on that weekend and they forgot. Whatever it's possible that your day is bad, it's certainly better than the day of any of the people that are laying in the bed that we're caring for. And if a person keeps that in perspective, it helps you to say, you know what, my day's not so bad, and I'm still involved in something holy. So, what is palliative care? Palliative care is really a response. It's a response to the way medicine, the way patient care used to be before we had all this explosion in technology. Now that doesn't mean that as palliative care we don't use technology to our advantage, but palliative care, our focus is on reducing patient suffering. Now, suffering comes in lots of different flavors. If it's pain, shortness of breath, nausea, vomiting, and diarrhea, that's the easy part. That's the stuff that I can help with. Medication-wise, various stopping medications, adding medications. This is what a doctor can contribute to the discussion. If we have a 35-year-old woman who's got metastatic cancer that has a prognosis of 2 or 3 months, and she has a 10-year-old son, and she doesn't have anybody to care for that son, we can't imagine that that patient is not suffering tremendously, wondering what's going to happen with my child after I leave the world. And that's not something I can fix with a little bit of morphine, a little bit of Zofran, or a little bit of dexamethasone. I can't even necessarily fix that with some Paxil. That is something where a social worker will come in and try to say, well, let's work on getting guardianship and helping you to make sure that your child is going to be cared for after you've left. And that's what I mean. Palliative care can only be done properly as an interdisciplinary team involving different patients with different people with different focuses. We can't imagine, so we understand whether we believe in God or not, we have to respect the fact that most of our patients do have some type of spiritual connection. And when a person is struck with an illness, especially when they're younger, but sometimes even when they're older, there's a question that they're asking. We know they're asking the question. And the question is, why me? I was a good person. And even if someone was a bad person, they think they were a good person. Or they say, okay, but maybe I'm suffering more than I should, right? And if someone was a good person, they say, why me? Now, unless I'm going to use my own spiritual stuff to help that person, that's where pastoral care will come in. Non-denominational pastoral care. A rabbi and a priest can minister to a person that is of a different faith, because we're not talking about the individual details of the faith. We're talking about the question, why me? And every, certainly monotheistic religion has to deal with that question. Why me? So palliative care is an interdisciplinary approach to reducing patient suffering. Okay? Now, there are some patients, and you'll hear this, I'm sure it happens in the walls of Downstate because it happens in the walls of Massachusetts General and Mount Sinai and NYU and every other institution. The patient is not ready for palliative care. I need someone to explain to me what that means. What does that mean? They're not ready for palliative care. What? If they're having pain, they're not ready to be comfortable? If they're having nausea and vomiting, they're not ready to stop having nausea and vomiting? Unfortunately, the specialty of hospice and palliative medicine, because of the hospice part of it, which we'll talk about shortly, there's a thought process that says, well, the patient has to be terminal for us to have palliative care. That is completely false. And I'll give you a story. When I was first starting out in palliative care, I got my my second job as a palliative care physician in a hospital. There was a 27-year-old young man with metastatic colon cancer who had miserable pain, was not eating, was losing weight, and was effectively dying. Dying because he was absolutely miserable and he was done living. So I was asked to see the patient, and the patient was really on a minimal amount of pain medications, and we'll talk about that. I adjusted his medications, put him on a PCA, gave him the control over the medication. Within a short period of time, he was feeling better. We were able to discharge him from the hospital within a week or so. He called me about 2 or 3 weeks later asking me if he can drive because he went home on a PCA. I said, no, I don't think that's a good idea. If you get arrested driving under the influence of alcohol, I can't imagine it's going to be if you're under narcotics. They don't have to do a drug test. They see it hanging. So I said, I don't think that's a good idea. He reported to his oncologist's office 6 weeks later, received chemotherapy, and lived for another 1.5 years afterwards. And that's because palliative care was able to interfere to stop his suffering, reduce his medical symptoms, allowing him to continue with therapy that was effective in helping him with colon cancer, which is generally treatable, especially at a young age. So that's why currently, if you look, the American Cancer Society and the American College of Surgery through the COS, the College of, I forgot what the group is, the two groups that certify cancer centers, have basically said it's a quality issue, they call it a quality indicator, for patients to have palliative care involved upon diagnosis of metastatic disease, regardless of the prognosis. And what's the reason for that? Well, reason number one is, if symptoms develop from the chemotherapy that patient is receiving, oncologists might be wonderful, wonderful physicians. They don't necessarily have the expertise, training, and experience to manage symptoms when they get more difficult. So involving palliative care might help those patients receive the treatment that they're receiving. So that's palliative care, and of course the other parts of it, to work on advanced directives, because we palliative care physicians, in addition to having expertise in managing symptoms, we also have expertise in communication. And we all know, if you are relating to another human being on this planet, you have to be able to communicate. Anybody who's married knows that. If you can't communicate, it's hard to have a relationship. A doctor-patient relationship is built on communication. Nurses and physicians and social workers, we work together by communicating. And communicating isn't always what's written in the medical record. That's one type of communication. But there's other types of communication, like picking up the phone and talking to each other and finding out what's going on with the patient, why the patient is suffering, and helping them. But we palliative care physicians are often likened to firemen. When there's a burning building, okay, police, EMS, and the firefighters show up. All of those people are heroes. They are risking their lives every single day in doing what they're doing. But when there's a burning building, all the police are doing is setting up a perimeter around the burning building not to allow people to go in. The police are not going into the building generally. The EMS guys are sitting outside in the ambulance waiting for the patients to be brought out so they can care for them. Who's running into the building? The firemen. So in complicated cases, in situations where there are either unrealistic expectations of the patient, unrealistic expectations of the doctor, unrealistic expectations of the family, we will go in and try to, through communication, help to resolve whatever those unrealistic expectations are, and try to obtain the patient's advance directives. Those advance directives can say, I want to be intubated, and I want everything to be done for me to the very end of life because that's what I want. Or it can be, you know what, if I get into this type of situation, I don't really want to die like this. As we know, most nurses who work in the hospital, special intensive care, there's an old saying that they have DNR tattooed to their chest. So if no one bothered to look at the chart until once they expose the person, they see, oh my God, there's a tattoo that says DNR. Did you see? Read it carefully. So we see that some people have very strong opinions regarding what they want to have done, and under certain circumstances that might change. So in palliative care, what we do is we identify the decision maker. If it's the patient, we support them in their decisions, and sometimes we have to do that vis-a-vis the family who wants more to be done, but we have to remind families that they're not the ones with the disease. The patient is the one with the disease. While the family might be wanting the patient to undergo all kinds of treatment, it's the patient that's going to have to suffer through the side effects of that treatment. Sometimes the patients are unable to make their own decisions. So we help families through the Family Healthcare Decisions Act to figure out who is the surrogate, support the surrogate or surrogates to make decision making. If there's a healthcare proxy, support the healthcare proxy in making the best decisions possible for the patient. And the key of those meetings is when you're meeting with the family, you have to stress, it's not what you want. I don't care that you're the patient's healthcare proxy. I don't care that you're the patient's daughter. I don't care that you're the patient's wife. You're not supposed to be telling me what you want. You're supposed to be telling me what the patient would want. That's what I need to hear from you. God forbid you get sick, then I can hear what you want. But you're talking about somebody else, and you're supposed to be a surrogate, which basically means you are deciding in lieu of someone else, but you're supposed to be telling me what they would want based on your intimate and close knowledge of that person. So that, in a nutshell, is what palliative care does. So there's no restriction on prognosis. A patient can see a palliative care person or team 2, 3, 4, 5 years before they die. And so there's no restriction. And so palliative care deals with symptoms, suffering, reducing suffering in an interdisciplinary fashion, and with goals of care discussions to make sure that patients understand and families understand what they're getting into. I'll give you another story. In some hospitals, they have a process where before a PEG, a trach, or a dialysis catheter is put in, they will require a palliative care consultation. Because physicians generally don't have the time, some of them don't have the communication skills, some of them don't have the patience, because these are not meetings with your hand on the door running out. These are meetings sitting down and talking to people at eye level. And many doctors don't have the training for that, to be honest with you. We're happy that they can communicate at all sometimes, right? So when we're communicating with the families, we want to tell them what's going on. So I had this one lady. She had promised her mother that she would never put her in a nursing home. Not uncommon. My mother, when I was growing up, basically said to me, and I'm sure she said to my brother and sister, if you ever put me in a nursing home after I die, I'm going to come back and haunt you. I don't want to go to a nursing, and for good reason. In the 70s, nursing homes were really, really nasty places. There's a reason why there's so many regulations for the nursing home world, even more than there are in the hospital world. It's for good reason. Just look back to the 70s and we'll understand. But coming back to, so I basically, I said to this lady they had called me, but unfortunately by the time I got to see the patient, the GI doctor was so quick that the peg was already in. And I come to see this patient, and the peg is in. And this woman, the patient had Medicaid and had 24-hour care through the city with Medicaid. And the daughter, who loved her mother dearly, but obviously had to keep bread on the table and support the household, was working 2 jobs. Not 1 job, 2 jobs. So, of course, I let her know that your aides will not be able to do the feeding. That's against their scope. It's beyond their scope of practice. The only thing an aide can do is present medications or food to a person and have them take it. But certainly, to give them food through a tube, this is beyond the scope of practice for an aide, and they could lose their licensure based on that. So I told her, well, how are we going to feed mom at home with the brand spanking new peg that she has? I said, there is really only one way. You either have to private hire, or mom has to go to a nursing home. Do you know that daughter took her mother home, didn't use the peg tube, and mom went home on hospice and died about 6 to 8 weeks later? Now, I'm not sure the peg tube would have prolonged her life at all. She had advanced illness. I'm not sure what it was. I don't remember. But in my assessment, I didn't think the peg tube was going to prolong her life. But nevertheless, this daughter had already signed consents for a procedure because no one had taken it to the next level. No one had painted the picture of what it looks like after the peg is put in. And we see that also with do not resuscitate discussions when we have the DNR discussions. Does the patient know that if they don't have a DNR, they will be put on a ventilator? And depending on what the disease process is, if they are unable to come off the ventilator, they will need a trach and a peg put in and go to a nursing home and live for the rest of their life, trach and peg in a nursing home? If you ask most people when they're healthy, would you want to live like that? Most people would say, no way! So once again, there's a disconnect, and that all comes from ineffective, lousy communication. Whatever the patient or family wants, based on the patient's wishes, it's our job to help them, as long as it's, of course, medically indicated. If a person has a week to live based on metastatic cancer, that's not a patient, that's a candidate for chemotherapy. We just have to know what the prognosis is. And palliative care physicians have expertise in determining prognosis. Anybody have any questions of what is palliative care? Okay, so now what is hospice? Very simply, hospice is an insurance benefit. Plain and simple. People have life insurance. Hopefully people in this room, some of us might have life insurance, right? You never want to be the beneficiary of your life insurance policy, because there's only 2 ways a life insurance policy has a payout. One, after the person dies, that goes to the beneficiary. It generally doesn't go to you because you can't take it with you. And there are certain policies that will allow you to access your life insurance benefit if, God forbid, you lose a limb or lose an eye or lose the use of a hand. Most people would rather, you know what, let me work and not take my life insurance benefit under that. So there's certain things that we don't want, but you have to have qualifications in order to get access to the insurance policy. The way hospice is set up in this country, certainly through the Medicare and Medicaid program and through the commercial and carriers, okay? Hospice is an insurance benefit. In order to access that insurance benefit, there's a qualification. Qualification number 1, in a physician's, not nurse practitioner, that's the way the law is written, in a physician's best judgment, the patient has to have a prognosis of 6 months or less. Now, what do we mean by best judgment? They have to be 51% right. They can still be 49% wrong, and the patient qualifies for hospice. In fact, if we look in the little pamphlet we have over here, the diagnostic criteria for putting a patient on hospice for dementia, okay? If you look and see what is the prognosis of patients average with those, it's a 55% mortality in 6 months. Which means if you put a patient on hospice for dementia, 45% of the patients who meet those criteria will still be alive 6 months later. Under Medicare and Medicaid, there is an unlimited amount of hospice benefit periods. So there's no such thing as, well, I only have 6 months of hospice, and then if I don't die, I don't have hospice anymore. That's not Medicare, that's not Medicaid. For the commercial insurances, sometimes they have a lifetime hospice benefit of 270 days. Okay, so in those situations, they'll only have 270 days, and then after that, it's not covered anymore. But most people who are going to qualify for hospice, the far majority of them are Medicare, Medicaid, especially in the area where you guys are servicing. It's mostly going to be those types of patients. So number one, they have to have a prognosis under the best judgment of 6 months or less. And they have to have a patient or a surrogate willing to sign what's called an election of benefits, stating that they will no longer seek curative therapy for the terminal illness. Okay? Now, there may not be any curative therapy for the terminal illness. There is no curative therapy for dementia. There may be curative therapy for a patient that has renal failure. It's called dialysis. It's called a kidney transplant. The patient may not want to avail themselves of that curative therapy for whatever reason, then they would qualify for hospice. And then someone has to be, and remember, it's not like an HMO where you sign up for an entire year and you are committed, or a mortgage where you sign for 30 years and then pay for 30 years. A person can elect hospice today and disenroll tomorrow. We love them just the same, because it's an election of benefits. And as long as they're electing those benefits, they are entitled to those benefits. If they choose not to elect those benefits, they get a phone call. By the way, there's this brand new medication that just came out. It's potentially curative for the illness that you had up until now. We thought you were terminal. Sign off hospice and go get chemotherapy. Now, that case is rare. The far majority of patients are often getting treatment, chemotherapy, all these kind of things, and without paying attention to the fact that it's really not helping the patient under the best of circumstance, and sometimes these treatments are actually hurting the patient. So that's where palliative care would come in. So if they elect hospice, they access the insurance benefit. And what does hospice provide? It's the best insurance benefit for those unfortunate people who qualify for it. Unless a person gets hit by a bus, shot with a gun, falls out of a building, most of the time, we know when people are dying, okay? Some physicians don't want to see it, families don't want to see it, patients don't want to see it, but we have an idea. And if you think about, since I'm talking with case management over here, when you have a congestive heart failure patient, that this is now the 5th hospitalization in the year, well, let me see, why do you think that is? It's either because they got a lousy cardiologist, or they're not complying with their medications, or we have exhausted everything that we can do medically to keep the person comfortable. That's a person that should be consideration for hospice. That doesn't mean they have to sign for hospice, but there should be a discussion about it. And according to New York State law, in 2010, there was something called the Palliative Care Information Act, which requires physicians and nurse practitioners, not residents, not interns, physicians and nurse practitioners, once they make a diagnosis of a terminal illness, to offer the patient and or their surrogate all treatment modalities, curative, palliative, and hospice. And then in 2011, there's something called the Palliative Care Access Act, which put the onus on hospitals, nursing homes, certified home health agencies. They didn't have to do with hospice because we were already doing it, but all adult homes, assisted living, to make sure that they allow access to this type of service in their facilities. No one has been prosecuted for violation of the law yet. Okay? And hospice, what does it provide? Yes. No problem. Do what you got to do. I'll record it so you can watch the end if you want. So what does hospice do? It brings expertise in what we call end-of-life care. We would like to think that any internist, any cardiologist, any specialist knows how to take care of patients at the end of the life regarding symptoms. They don't. And if you think about it, most of the time, once the patient elects hospice, sometimes the specialist will disappear. Why? Because there's nothing more they can do for the patient. Most physicians go into medicine to help people, and it's very hard to be dealing with a patient you cannot help. Doctors don't like to feel helpless, just like social workers and nurses don't like to feel helpless. What they need to recognize is they're not helpless. They're only helpless because they're thinking to themselves, I have to cure the patient. But making patients comfortable, you don't have to be helpless. There's a lot of things we can do to make sure patients are comfortable. And the first thing we need to do is get them home. And that's where hospice comes in. It's an interdisciplinary approach to reducing suffering in patients that have a prognosis of 6 months or less, where they are visited at home by end-of-life specialist nursing, social workers, pastoral care, who have expertise in identifying as the patient is declining, supporting the family to care for the patient at home with medications, oxygen, and equipment. And unlike home care, which under Medicare is very limited, the patient will go home for a home care episode under very rare circumstances unless they have Medicaid. Home care is usually in and out of the house 4 to 6 weeks. 2 months, they have to do a lot of documentation to justify that. Once that's done, home care is gone. Once home care is out of the house, what happens sometimes? Patient comes back to the hospital. So on patients that are not terminal, absolutely. But on patients that are terminal, we should offer them home care as one option, but we should also think about offering them hospice as another. And hospice is basically home care on steroids with expertise in end-of-life care. Physician, which every patient who goes with hospice is assigned a physician with specialty training or expertise in caring for patients and using medications in ways that other physicians are not accustomed to using for the care of patients as they are dying. They're entitled to continue with their primary physician. Nobody has to give up their doctor. If they have a doctor for 20 years that's been caring for them, we encourage the patient to elect the doctor as the primary physician, and we encourage the physician to remain involved. Some patients don't want the doctor anymore. Some doctors don't want the patient anymore. And sometimes it's mutually agreeable they don't want each other anymore. And then what happens is the hospice physician becomes the primary physician. What happens if a patient's at home and they're given their medications and under the tongue medications and various things, and let's say they have an escalation of symptoms. They're a CHF patient, and just like what happens with clockwork, every 2 months the patient starts getting shortness of breath. Instead of reaching for 911, what they reach for is they call hospice. Hospice then sends a nurse to the house if there is that level of time. If there isn't, hospice can then transfer the patient by ambulance, not EMS, by ambulance to an inpatient hospice facility where the symptoms can be managed in a very, very aggressive way. And I'll tell you exactly what I mean by that. There are patients that we take care of in an inpatient hospice unit that the only place you can put the patient in this hospital is in the ICU. I'll give you an example for the nurses in the room. If I have a patient on a diluted PCA, 10 milligrams an hour with 20 milligrams every 15 minutes PRN, with Ativan 2 milligrams Q4 hours around the clock and Phenobarb PRN, where does that patient have to be in this hospital? ICU. Your regular med surg floor, maybe they can do morphine drip at a low dose. Maybe they can't even do drips at all. They can just do IV push medications. In our inpatient hospice unit, we can manage patients like that. And it's not just Downstate. Sloan Kettering, there are hospitals that can't manage patients to this level. And they come to inpatient hospice, whether it be from home to the inpatient unit, or whether it be from the hospital. They're no longer able to have curative treatment here for whatever reason. The symptoms are still not yet managed. The goal is for them to go home, but right now the symptoms are not managed. We can transfer patients from the hospital here to an inpatient hospice unit. And the closest one that we have to here is probably between Borough Park and Menorah. Borough Park might be geographically much more advantageous. Menorah is gorgeously more advantageous. There's a big difference between being in Borough Park, which is a wonderful neighborhood, but there's no ocean views, and being at Menorah, which is in Manhattan Beach, where there's plenty of parking. And the rooms, and if you want, we have a digital thing on the web. If you want to look it up, you're welcome to come visit if you want. Basically, every patient has a room that's about half the size of this room. That's the patient's room. And then next to the patient's room is another room for the family that's the same size as the patient's room. And then there's a common family area that's huge, and a library and a kitchen. The goal is to try to reproduce what it would look like at home in a hospital environment. If you guys deliver babies over here, yes? Is a child, yes? No? You know what you try to do is you try to have that birthing room, right? Where you have that chair, they sit in while they're in labor, and then within a very short period of time, you don't move the patient to the operating room. The operating room moves to the patient, and now that chair becomes an OR table. We try to do the same thing in hospice to try to make sure patients are comfortable. If we can get their symptoms under control, we will send them home or to a nursing home if need be. Many of the patients come to us and they die because they're at the end of life. But the key here is we have to be able to identify which patients would qualify for this program and be able to have that conversation. And I have to be honest, the responsibility for that falls on physicians and nurse practitioners. Social workers, nurses can certainly help with that, okay? But if a patient says, well, how do you know my prognosis is less than 6 months? Well, that's already beyond the scope of practice of a nurse. She can't say, or he can't say what the prognosis is. Heck, a nurse is not even allowed to make a diagnosis unless it's written on the chart. So once again, we have to all recognize where we fit in the realm. We all need each other to help each other, but when we're helping each other and working together, this is how we help our patients. And that, in a nutshell, is what palliative care is and what hospice is. Just one other thing about hospice, there's one other level of care, it's called respite. Let's say you have a patient at home, and the family is caring for this patient at home, and lo and behold, there's a bar mitzvah, there's a communion, there's a wedding that's out of state, and all the family wants to go, but they got mom at home and they have no one to care for her. We will bring that patient into an inpatient hospice unit or to a nursing home under the hospice respite benefit. Doesn't cost the family any money. They can do there what they got to do. They get 5 days, and they're entitled to that every 60 days. And it can just be simple like this. You know what? Mom has been up for the past couple of nights. We've been medicating her. We want to keep her home. But you know what? We need a break. We're exhausted. That's an indication for respite. So it's really, and I'm just touching on what hospice, it's a little bit of, I tried to give palliative care in hospice, but it's really a wonderful program for those people that unfortunately qualify for it. Okay. Does anybody have any questions? I tried to. And the reason why I've gotten, thank God, a little bit good at this is because I've done a number of these already. So I'm trying to anticipate the questions I've been asked before and answering them as I go through things. But does anybody have any specific questions? Yes?
You do respite for patients that's not necessarily hospice or palliative.
Okay, so if the patient is not a hospice patient, then hospice is not involved with that patient, right? They have to elect the benefits and they have to qualify for hospice. There is no other program like this. There's no respite. A person who's at home and having a difficult time with mom can't bring mom into a nursing home and have Medicare pay for that. They have to have a 3-day qualifying stay and they have to have a skilled need. They have to have both. If they're missing either one of them, they don't get Medicare to pay for their nursing home stay. If they have Medicaid, and sometimes you can get a PRI done at home, and the patient can be transferred into the nursing home, but that's assuming the patient has nursing home Medicaid. If they're at home, they have community Medicaid. So really, That's not, our system is not designed for that, unfortunately.
So I called today trying to get authorization for one of my patients that I'm sending to hospice. So they say is it inpatient hospice?
Ah, great.
Or it's inpatient, or is it hospice? And so I'm all confused.
So let me help
I
you.
had to call Gina. Right?
Let me help you. I got news to you. Out of the phone calls I've received from the hospital here, because what happens with Menorah, any patient that comes to Menorah inpatient hospice unit, I have to get a phone call. I'm either getting called from one of our nurses that work here, or I'm getting a call directly from a physician or a nurse practitioner. And there's it's not just here, so don't feel bad. There's some education. I'd love to come back and maybe speak to your physicians if possible to talk to them. But let's understand this. Hospice is designed by the Medicare program for patients to die at home. Why? Because that's where patients generally want to die, at home. Unfortunately, sometimes there are mitigating circumstances, especially given depending on where our hospital is situated, various socioeconomic realities that often preclude that from happening, either from safety concerns or from financial concerns, whatever it might be. So, inpatient hospice, which is hospital-level hospice. Let's understand this for a second. If I have mom at home, and she goes to a doctor's office, and the doctor listens to her lungs, and she's got a fever, a low-grade fever, and thinks she has pneumonia, but her saturation is 95%, and she can take pills, and it's relatively safe for her to take pills, does she qualify to be admitted to a hospital? Absolutely not. Why? Because hospitals are only allowed to care for patients that cannot be cared for at home, which means there's something you're going to do for them here, IV antibiotics, ventilator, pressors, whatever procedures that cannot be done in the outpatient setting. So you know, and many case managers, you know what I'm talking about, when the HMO is denying you on the second day of the admission because they're saying further hospitalization is not medically necessary. What are they really saying? You can keep the patient in the hospital. I don't care. We're not paying. Why are we not paying? Because in our estimation, based on the limited documentation that we're being sent, okay, God forbid that you come see the patient, based on the documentation they're being sent, they don't see a justification for acute level care. Am I speaking everybody's language here? Yes. Now we transfer the same concept to hospice. Hospice is designed for a person to be at home. You don't come to a hospital to die. You come to a hospital when you have problems that can't be taken care of at home. If a patient can be made comfortable in a home setting because they can take sublingual medications, oral medications, rectal medications to keep them comfortable at home, they don't qualify for hospital. Just like you guys on a day-to-day basis have to justify why the patient's in the hospital, we have to justify why the patient meets criteria for inpatient hospice. And the Medicare criteria is like this. Since all of our patients are technically dying, nobody's getting better. They might be feeling better and more symptomatically controlled, but nobody's getting better. Unlike a hospital, they leave the hospital when they're getting better. Our patients are generally not getting better. Our patients are generally declining and getting worse. So in order to qualify for inpatient hospice under Medicare, and probably Medicaid as well, there have to be symptoms that cannot be managed in an alternate setting. Which means the symptoms have to be such that they need medications either at doses or at intervals or at method of administration that cannot be done in a home setting or a nursing home setting. Yes. Those are the patients that qualify for inpatient. They will come to us. I will get their symptoms under control. I will then change the medications around to a delivery that can be done at home, and then I will discharge them home or discharge them to a nursing home. Okay? But when I'm getting phone calls, the kind of patients I need to take to GIP, if that's what we're talking about, which is covered by Medicare, are patients that have symptoms that cannot be managed. Many times, not just here in other places, often I'm hearing the case, the patient's on, as we say in Yiddish, bupkis. You know what bupkis is? Nothing, okay, as far as medicines are concerned. Oh, the patient we want to send the patient to Menorah. Okay, what does the patient have? Well, the patient has a fever. Okay, that's nice, give Tylenol. What am I going to do differently, right? The patient has pain. What medicine's the patient on? Oh, we're giving the patient Tylenol. Really? Just Tylenol? Okay, so sometimes it's a matter of educating who's calling me to say, why don't we try this regimen, give it 24 hours and see what happens. If you can't manage the patient with sublingual Roxanol, say 5 milligrams Q4 around the clock and 5 milligrams Q2 PRN, that would be an indication for coming to a GIP unit. Or if this patient's still having nausea and vomiting, they don't have a good oral route, and they need symptom management, that would be. So there's certain things, and I'm more than happy to come back and specifically talk about that because that's a talk in and of itself. But generally, it's symptom-based, and that's why when you're going to call me or your doctors are calling me, the first thing after I hear the patient is terminal, yes, I understand, the patient is terminal. You wouldn't be calling hospice if the patient wasn't terminal. They think they're done. Or we have the patient has metastatic cancer. Okay, now what? What symptoms is the patient having? You'd be surprised sometimes the doctors don't even know.
Yeah.
And not just from here. Or I'll ask, well, what medications is the patient on for symptoms? They don't even know. And if they know what medications the patient on, tell me how many doses the patient received in the past 24 hours. Lights are on, but nobody's home. And please, this is not just Downstate. This is NYU, this is Sinai, this is part of what has to happen under the medical profession to us to start to look. I will see the same patient as another doctor, and that doctor will say, well, that patient looks comfortable. I'm like, are you freaking kidding me? What's the patient's respiratory rate? It's 28. Well, how's that comfortable? Are you breathing at 28? Right? Or they'll see a patient that's agitated. Well, why is the patient agitated? Let's give some Ativan. No, the patient's agitated because they're short of breath. Like I tell the residents and fellows, if I take a bucket of water and I take your head and I stick it in the bucket of water, whether you have an anxiety disorder or not, you get very, very agitated if you can't breathe, okay? Sometimes these patients are having pain. They have dementia. They can't communicate they have pain. How are they communicating the pain? By misbehaving. They're not misbehaving, they have behavioral issues. Because how else are they going to communicate to you that they have pain? They can't say, I have pain, give me pain medication. No one's looking at their face. No one is noticing that they're blocking their midsection. No one is noticing that they're wiggling in the bed. When I see a patient in a hospital, they have mittens, I know their symptoms are not being managed properly. Do you know how many patients in Menorah have mittens? 0. And if they come in with them, they're taken off immediately. Because we don't have to physically restrain anyone. Because our goal is to make sure they're comfortable, so we give them medications and address their suffering and symptoms. Just think about when you do your rounds and you go around the hospital. You're seeing these patients with mittens on. You're seeing these patients tied up to the bed. You're seeing these patients with behavioral issues. A lot of that is unmanaged symptoms. These people are suffering. Tying them up doesn't decrease their suffering. It increases their suffering. So it's a real paradigm shift that has to happen in hospitals and nursing homes. And the only way it's going to change is with education and programs like this so we can talk about it. Okay?
Yeah.
Did I clarify that? And if you have any questions, you can always call. Okay? All right, and the authorization, as far as hospice is concerned, if it's a commercial insurance, they have to get an authorization, right?
Yes.
But regarding GIP, if we will accept the patient if they're terminal to home or to a nursing home, unfortunately, when patients only have Medicare and they don't have Medicaid, they get screwed, right? Because you think about the logic. This makes no sense. I wish I could have a meeting with someone in politics to give them a knock in the head. If you have a patient with dementia, there's multiple studies showing that patients with advanced dementia, a feeding tube does not help them. And even if it does help them, most people don't want to live like that, right? Would you agree with that? Okay. If you put a feeding tube in a patient that only has Medicare, they have 100 Medicare days. There's not a nursing home in Brooklyn that won't take that patient, especially if they have straight Medicare, right? Okay? But if they decide, you know what, we don't want a feeding tube, mom wouldn't want to live like that, oh, well, she doesn't qualify for a nursing home. She's got to go home. Is that stupid? That's the most ridiculous thing that we've ever heard. I think, personally, hospice should be a skilled need. And Medicare can set the guidelines anywhere they want. They can make it a partnership between a nursing home and a hospice organization, sharing social workers and pastoral care people together. and have a cost structure that allows the nursing home to bear most of the brunt from the cost, but most of the benefit with hospice's expertise? And then why shouldn't a patient get 100 Medicare days to live out the life in a nursing home if there's no safe home environment for them? It's criminal what we're doing to people. But if they're poor and they qualify for Medicaid, then they got the keys to the city. Or if they got plenty of money, then it's no problem. They just shell out the bucks. But if they're in the middle, like most of us are, we're screwed. Okay? Any other questions? All right, have a wonderful day, everyone.
Thank you.